I will be presenting on Ionic or Acoustic, a pair of short-term outcomes, pain, strength, and neurological signs between phonophoresis and iontophoresis in people with carpal tunnel syndrome. I will pause for one moment here, giving you the chance to review the abstract. Carpal tunnel syndrome is an overuse condition that can be secondary to chronic inflammation. I'll be looking at CTS for this comparison, as it is fairly common across settings and can be treated with both phonophoresis and iontophoresis. I have also personally noticed that there is often not a significant why as to one is the chosen intervention. Iontophoresis and phonophoresis can be used to deliver topical anti-inflammatories, both steroidal and non-steroidal. However, their mechanisms vary significantly. Iontophoresis primarily delivers the medication through electromigration and electroosmosis. Typically, these treatments last anywhere from 10 to 20 minutes, and this one's at a little bit lower of a price point. The iBrevis unit costs about $307. In contrast, phonophoresis mainly uses cavitation and microstreaming to deliver the medication. These treatments can last anywhere from 5 to 10 minutes, and the Chattanooga, the one that we have in our classroom, costs around $6,900. I have a few hypotheses of why clinicians I have worked with may be using each intervention over the other. The more salient contributors to delivery method choice would be athletic trainer preference, athlete preference, and available resources. However, such superficial reasoning does not justify one delivery method versus another. As such, it is of utmost importance to give a deeper dive into some of the short-term outcomes that could differ between each delivery method. To guide the deeper dive and better employment of this modality, the PICO question format was applied. My PICO question is, in people with carpal tunnel syndrome, does phonophoresis or iontophoresis create better short-term improvements in pain, strength, and nerve function? Moving on to the summary of the available evidence. I'll be including a total of 5 articles in this review, the first one being a systematic review of therapeutic iontophoresis. This review analyzed iontophoresis factors affecting delivery across skin, including current, drug charge, drug ionization, skin resistance, skin permeability, ion competition, electron configuration, duration, and hydration. It was observed that skin pharmacokinematics can vary person by person, meaning that for a protocol to be the most effective, it must be slightly personalized, making this a limitation of iontophoresis by putting a more burden on the clinician and the researcher. In addition, there are also numerous reports of skin irritations and burns. In retrospect, iontophoresis is relatively uninvasive, but the potential for harm for patients is yet another limitation of using iontophoresis. Overall, though, iontophoresis does result in drug delivery across the skin. The next review is a review of ultrasound-mediated transdermal delivery of phonophoresis. This is selected for an overview of phonophoresis parameters and safety. This review looked into individuals' parameters' effect on overall drug delivery and is thought to provide insight on specific parameters' effects on mechanisms in the skin. In general, high frequency tends to lead towards higher in-skin cavitation as a primary enhancer of drug delivery, meanwhile low frequency increases transdermal delivery. Overall, though, phonophoresis does result in high drug delivery. Both of these reviews were a level 1 level of evidence. Next up is a systematic review of 24 RCTs on CTS in the physical therapy setting, combining electrophysical modalities and phonophoresis. Within this review, 2 RCTs directly compared iontophoresis and phonophoresis for alleviating symptoms in carpal tunnel syndrome. I will be noting here that the sample size for both of these RCTs were relatively small. However, both therapeutic modalities showed a decrease in short-term carpal tunnel syndrome symptoms. Phonophoresis outperformed iontophoresis in pain, grip strength, pinch strength, and nerve conduction indices. Further, a difference favoring phonophoresis over iontophoresis was observed while not being statistically significant in functional measures. One of the RCTs had a very high level of evidence, really great transparent methods, well-blinded, good crossover design, while the other had a lower level of evidence. Next up is a randomized double-blind comparison of CTS intervention. All groups improved on the Boston Carpal Tunnel Syndrome questionnaire, both the symptomatic and functional sections. Phonophoresis with dextromorphin elicited the greatest reduction in both. However, between groups there was a non-statistically significant difference. It should also be noted that distal motor latency decreased by a clinically significant margin to phonophoresis with dextromorphin group. Again, in this RCT, we do struggle with a smaller sample size, while the actual methods were very transparent and good, though, rating at a higher level of evidence, but a limitation is a small sample size. Moving on to a systematic review and meta-analysis of 7 RCTs for treatment of carpal tunnel syndrome. This review is the best example of overcoming the small sample size limitations displayed in most RCTs in this population, making the findings from the study the most reproducible in both the clinic and in our own practices. This review performed a pooled analysis across RCTs comparing intervention for CTS. reporting on the visual analog scale, carpal tunnel syndrome questionnaire, and neurological outcomes. Across these all, iontophoresis only outperformed phonophoresis in median nerve amplitude conduction. The RCTs in this study showed a variety of quality, however, the actual study was transparent with its methods, warranting its inclusion as a relatively large sample size for comparison. Again, moving back to one point, if there is no statistically significant difference between all of them except for that one aforementioned factor, that means that iontophoresis and phonophoresis are essentially performing exactly the same for improvement of short-term outcomes. Moving on to the clinical bottom line, thorough shots should go into therapeutic intervention selection, basing selection on availability, tolerability, contraindications, equipment time, and patient preference. The most consequential findings of clinical practice is that iontophoresis is commonly reported as being uncomfortable for the patient, and in a direct comparison to patient outcomes, strength, pain, neurological outcomes, there's a low level of evidence allowing for a weak recommendation of phonophoresis over iontophoresis. Again, they performed nearly exactly the same. While both can yield the same short-term outcomes, the slight variability of phonophoresis and reduced invasiveness leads to phonophoresis being the preferred method for treating carpal tunnel syndrome in the short term. Aggravating findings across the reviewed literature, the best practice protocol for phonophoresis should be to use 1 millihertz, a continuous duty cycle, 1.0 for the intensity, 5 minutes using 10% hydrocortisone cream. Moving on to the education implications. For these settings, the curriculum should be rooted in a mechanism difference between interventions. This should be done for athletic training students, physical therapy students, and I think would also make a great continuing education option. I think it's very important for us to begin with understanding the specific mechanisms and then reviewing into an actual specific case-by-case intervention choice and like how they selected their parameters. This will lead to the best outcomes available for our patients. We'll also understand that our clinicians are always critically thinking about what they're doing. Again, while I was able to find a modest favorability of phonophoresis, you still need to employ critical thinking to pick the best possible intervention. Across the reviewed literature, several large gaps still exist. Most notable, there is a need to compare larger, standardized, by-protocol, randomized controlled trials that directly compare phonophoresis and iontophoresis. These RCTs must use a standardized drug prescription, consistent parameter settings, and uniform outcome measures. Further, researchers look to further delve into the patient-centered outcomes, comfortability, and subjective favorability, as these appear to vary significantly between interventions. Future research would also benefit clinicians if it was done in other pathologies and if CTS was also grouped by severity. Again, a major drawback to all these studies is that CTS was just grouped together no matter how severe the CTS was. Here are my references. Any questions now from anybody except for Jet, please?